Now we move from diagnosis to therapy. We already heard quite a bit about it from the previous speaker. Why do we revascularize? We have medical treatment, of course, to lower the risk, but why do we revascularize when patients have coronary stenosis? One reason is to get rid of the symptoms, to make sure that the patients can exercise and live their life without having chest pain as a symptom. And the other reason, of course, for revascularization is to improve prognosis. And all of this is always based on simultaneous treatment with medication for angina control and risk reduction, what we call guideline-directed medical therapy, GDMT. Now we know that revascularization of coronary stenosis is very effective to remove angina. The ischemia trial, which was published in 2020 and looked at 5,000 patients, showed that the possibility to become angina-free is 30% higher with revascularization than with medical treatment alone. It's not 100% is angina-free, but we increase the likelihood to be free of angina by 30%, free of angina by revascularization as compared to medical treatment. And the recently published Orbiter True trial, which also compared revascularization and medical management in a sham-controlled design, has very complicated graphics about the frequency of angina following PCI on one hand or placebo of PCI and only medical treatment on the other. But if you look at the graphic, it says that after 84 days, so approximately 3 months, only 20% of the patients who underwent PCI still had episodes of angina, while 45% of the patients treated by medication still had episodes of angina. So PCI revascularization can reduce the amount of angina significantly and substantially, but it cannot eliminate angina in every single patient. So revascularization is effective to reduce, but not to completely eliminate angina. And this is why the guidelines recommend, as a class 1A recommendation for revascularization, those patients who have a chronic coronary syndrome underwent medical treatment for angina relief, but are not symptom-free from symptomatic treatment of angina in patients with chronic coronary syndrome. And we all know how effective this can be when we revascularize for symptoms. So revascularization can significantly improve symptoms, but whether revascularization, whether by surgery or PCI, improves outcome is less clear. In particular, when patients are on very intensive statin therapy to lower their cardiovascular risk. This again has been demonstrated by the ischemia trial, which I'm showing again here. More than 5,000 patients randomized. They all had a certain extent of ischemia on non-invasive testing. In all of these patients, left main stenosis had been ruled out by CT. And then they were randomized with angina and a positive ischemia test to either undergo initially conservative management, medical therapy only, or invasive angiography with the aim of revascularization. But in both arms, in the invasive arm and in the conservative arm, high-dose statin therapy, atorvastatin 40 to 80 milligrams, and aspirin were given for risk reduction. And we all know the result. That was 4 years ago. No difference in the combined primary endpoint of myocardial infarction, cardiovascular death, heart failure, cardiac arrest, and unstable angina hospitalizations. The data suggested that in this entire cohort, there was no advantage of a routine invasive management. However, there was a reduced rate of myocardial infarction, particularly in patients who had severe coronary artery disease, a Duke score of more than 6, which means 2-vessel or 3-vessel disease with involvement of the left main coronary artery. So when there is severe, anatomically severe coronary artery disease, there is a prognostic benefit of revascularization. And another analysis of the ischemia trial showed that in patients who had impaired left ventricular function, there was also a significant benefit regarding the combined endpoint by revascularization. Impaired left ventricular function, significant benefit of revascularization on the combined endpoint. So this is, of course, taken up in the guidelines. What are the indications to revascularize to improve prognosis? And the guidelines say if there's multivessel coronary disease and left ventricular ejection fraction, That's a class 1 recommendation for revascularization by bypass surgery as compared to medical therapy alone, as long as the patients are considered low risk for surgery. If the patients are considered high risk, there's a class 2B recommendation for revascularization by PCI. This is patients who have reduced left ventricular function. In patients who have normal or not significantly reduced left ventricular function, there's a prognostic reason to improve outcome to revascularize patients who have significant left main stenosis, who have significant 3-vessel disease, and for patients who have single or 2-vessel disease, which includes the proximal left anterior descending coronary artery. In all of these, there's a class 1 recommendation to revascularize not only for symptoms, but also to improve their prognosis. So in the patients on the left hand, this patient might have ischemia and angina, but it's the mid-circumflex or even the distal circumflex that is affected here. Revascularization will probably improve symptoms, but will probably not impact prognosis. On the right-hand side, you can see a patient where the left anterior descending in its proximal segment is affected with a severe stenosis. And in this case, revascularization, according to all that we know, will benefit symptoms and prognosis at the same time. Now, how should be revascularized? There's a class 1 recommendation to explain to the patients all options: medical therapy, surgery, and PCI. And always when you make a decision about PCI versus bypass surgery, we have to include considerations about the surgical risk of the individual patient. Some patients are very low risk for surgery, others, of course, are higher risk. For the left main coronary artery, if it needs revascularization, there's a class 1 recommendation to perform PCI. And there's now also an equivalent class 1 recommendation for bypass surgery. And there's now an equivalent class 1 recommendation if the syntax score is no more than 22 for PCI. If the syntax score is more than 23 or more, the recommendation for PCI should be considered, but no longer a class 1 recommendation for PCI. We always have to explain the options to the patient, and we have to balance surgical risk, which is very important. Some patients are very low risk for surgery, others are higher risk for surgery, and this needs to be taken into account. If there's diabetes and the patient has multivessel disease, there's strong data that support the use of bypass surgery. So class 1 recommendation for multivessel disease and diabetes, and only class 2A recommendation for PCI in this situation. And then finally, as I said before, reduced ejection fraction. Class 1 recommendation for bypass surgery when there's multivessel disease and patients are considered operable, and a lower recommendation, a lot lower, only class 2B for PCI. We already heard that intravascular imaging should be used in the context of revascularization. Class 1 recommendation to use pressure measurement to determine the hemodynamic relevance and to identify the lesions for revascularization in multivessel disease. And you already mentioned that QFR is also mentioned now. It's based on one single outcome trial which was performed in China. And this is what put QFR into the guidelines. And we also had a nice talk already about the use of imaging, particularly to make sure that the stenting result is optimal. Rule out dissection at the beginning or the end of the stent. Make sure that there's full stent expansion and stent apposition. This is why there's a class 1A recommendation because of 2 trials, the Renovate trial and the October trial. Class 1A recommendation to perform in complex lesions intervention with guidance by intracoronary imaging. Complex lesions are long lesions, left main, and true bifurcation lesions, which means that both branches have at least 2.5 millimeter diameter. After revascularization, what's new for follow-up? Following revascularization, we know that we need to reach an LDL cholesterol goal of 55 milligrams per deciliter, and there's a new class 1 recommendation for a new agent, bempedoic acid, if statins and ezetimibe are not sufficient. For dual antiplatelet therapy, there's now a class 1 recommendation to shorten DAPT to 3 months or less if patients are at high bleeding risk. This is partly because our stenting results have become better, so that the risk for stent thrombosis is lower than it used to be. And even in patients who have no high bleeding risk, but they are considered to be relatively straightforward, easy coronary cases with a low ischemic risk, low risk of stent complications, DAPT can be shortened, even in patients who have no high bleeding risk with a class 2B recommendation. And finally, based on 2 trials, one of them the host exam trial from Korea, it is now mentioned that for long-term treatment, after PCI or after myocardial infarction, you can either use aspirin or clopidogrel, and they are equal, they're alternatives, and clopidogrel was previously only suggested as an alternative if aspirin was not tolerated by the patient. Now it's an equal choice between clopidogrel and aspirin in the long-term treatment. Finally, something that might become very important are the drugs that support weight loss, the GLP-1 receptor agonists. There's one trial that has shown improved outcome if patients who have obesity and who have coronary artery disease are treated with semaglutide. So there's now a class 2A recommendation based on one trial for a better outcome to use semaglutide, GLP-1 receptor agonists, in patients who have a body mass index of more than 27, even if they don't have diabetes. So a short summary of what is new in the context of revascularization: slight upgrade for PCI for left main revascularization, class 1 recommendation for intracoronary imaging in the context of revascularizing anatomically complex lesions, strong considerations for shorter dual antiplatelet therapy than we used to do, clopidogrel as an alternative to aspirin, and then as far as other drugs are concerned, for risk modification, the use of bempedoic acid. It can be an intermediate step, so to speak, between escalating to PCSK9 inhibitors and not having sufficient lipid-lowering potential with statins and ezetimibe, and potentially the use of GLP-1 receptor agonists such as semaglutide. Please be advised, and I think all of you know this, that all of the guideline texts can always be accessed completely freely on our website, www.scardo.org, along with a lot of educational material about the guidelines. And thank you very much for your attention.